I did change the topic, apologies for that, but I thought it was a bit more interesting to talk about some stuff that is relevant for everybody and not just another, I can tell you about my service and about what we do. So hopefully, a couple of confessions to make. One is that this case that I'm talking about kind of makes me particularly vulnerable. And then the other thing that I wanted to say is that I'm very interested in audience participation. So I'm going to ask for people to participate, if that's okay. I know it's before afternoon tea, but perhaps we can, help participate in this. So we'll talk a bit about a case, talk a bit about reflection, and there's some very adept and advanced people to talk about reflection in this room. So I'm going to, just leave it there. But thank you. If you can participate, that'd be great. I want to talk a bit about transformational learning, and hopefully we'll have some time for questions. So decisions, everyone makes them. We spend half of our days making decisions. I make some good ones and some not so good ones. And I got interested, my history is I got interested in medical education, and I was the clinical dean of the medical school in Taree. And I was trying to understand how students make decisions, because we have to teach them how to make decisions. So I tried to think more about how I message and mentor decision making. And I'm wondering if I can get some participation in terms of what makes a decision? How do we make, not just, I guess, let's put it in context. It's a Pal Care Day. So let's talk about how do we make some decisions in palliative care? In any clinician level, how do we make decisions? What are some of the guiding principles of our decision making?
I think we need information.
Information, I got, information, as in you need more information as the question, or you just...
First I need to know what the question is.
Okay, the question is, what are some of the components of decision making?
Yeah. Well, I think first is knowing what you're trying to answer, and then gathering whatever information's available to you, figuring out what you're missing, finding that, and then making the best decision you can, and then giving yourself grace when you feel like you need to change that decision a bit afterwards.
Yeah. Oh, I like that. Yeah, that's really good. Thank you. Anyone else got anything else to offer about?
Could you say that again for online?
I like to know where the system failures are in that person's daily living, so I can get to the nitty-gritty and make the most.
So can I put that in, is that context? Do you want to know more about their context?
I'm an occupational therapist.
Sure.
So I need to know about weeing, pooing, getting to bed, getting up the front steps.
Fantastic.
Yes, no, yes, no, yes, no. And so I can, because people want a lot from us because we're scarce resources, and I can't do everything in 5 minutes.
Absolutely. Yep. Thank you. So we got so just to summarise so far, we need more information, we need to understand context. Kate, did you have?
Yeah, I was going to say sometimes, and hopefully a lot of the times, we base our decisions on what the patient wants.
Yep.
Yeah, what direction they want to go.
Absolutely. So shared decision making then, absolutely. And someone else.
We often talk about gut instinct and intuition and what we're seeing. Sometimes without really understanding what it is that we're seeing, but knowing at a level that there's a change happening.
Great. Yep, I agree. So we're using some sort of theory-based stuff as well as some intuition or some experience-based stuff I'm going to suggest as well. Yeah? Oh, wow, we've got lots of participation here. Amazing, yeah.
I think a lot of people make decisions based on their emotion, even if it doesn't go with their head.
100%. So can you hold that thought? Because that's, fundamentally that's where I want to head. So this is a case of a 53-year-old woman who I was asked to consult. She was from a supported independent living environment, had lived there her whole life, or with her sister, and she had the intellectual capacity of about a 9 or a 10-year-old, and she had a very prolonged admission with what was thought to be a UTI sepsis based on a whole series of behavioural changes. And after tons and tons of different specialists came along and assessed her, a geriatrician finally went through all her case notes and went, okay, it looks as if this fits a pattern of likely Lewy body dementia. So unfortunately, her condition was very, very difficult to manage, and there was a lot of distress. Now, when I say distress, everyone says, okay, yeah, sure, I've seen distress. That's fairly self-evident. What was that phrase about, you know when you see it? Yeah, something along those lines, okay? So it looked like distress, but this woman was screaming and audible from the end of the corridor. So we work in a 1950s built hospital and, great insulation, all the rest of that. So at the end of the corridor, you can effectively hear this woman screaming, and all the way down the corridor. Staff were distressed, her sister was distressed, and her family were distressed. Her care workers, the disability support care workers who'd come in to visit her, were also very visibly distressed. And she was starting to exhibit behaviours that were self-harming as well. So she was hitting her head repeatedly against the bed, against a wall, trying to throw herself out of the bed. So they did all sorts of investigations, sedated her to do those, MRIs, CTs. She had pan scans of everything. There wasn't any kind of clear way to determine what was happening with this woman. And then guess what? They're like, cool, pal, care. So I come along and what do? What are some of the issues here? Does this woman have a clear terminal diagnosis? No. So I'm concerned already, right? I don't think we need spider senses to go, okay, well, is this a bit of a difficult conundrum of why am I involved as pal care when this woman doesn't have a clear terminal diagnosis? So what do people think? What do I do? Yeah, so clinical assessment I got offered. Yeah, clinically she's accessible to the extent that you can hear her scream and that you can't go near her or touch her because she'll try and hit you. Yeah, so she's had all her scans. She's had all her bowels checked. She's had urine scans. She's had CT head. She had an MRI of her head. Yeah, so she's had investigatorials. A pain assessment in a 53-year-old woman with very severe intellectual impairment. Sorry? Very, very tricky. Anyone else? Any thoughts on what we can do?
I'd probably talk with her sister, who's her enduring guardian.
I like that.
30-year carer, who's probably got a fair idea of history and changes.
Thank you. Yeah, we did that. That was, yeah. Yeah, absolutely. Yeah, it's at the bar, man. Yeah, no. So absolutely talked to her sister, had lots and lots of family discussions, and eventually, I know this is where it gets a little bit awkward, we headed down this path of sedating her. So not only did I talk to her sister, but I phoned lots of friends, and I phoned trusted colleagues and went, oh my God, am I killing this woman? This doesn't feel right. And it was super, super awkward. And fortunately, I did get a bit of grace because people went, oh, well, I really wouldn't know what to do there either. And can we try sedating her for a period of time, winding her back and seeing if any of that stuff resolves? So we did that. And unfortunately, that didn't work. And we ended up terminally sedating her. Now, if you're horrified, I am too, believe me, and it's a couple of years later, so absolutely. The family, however, were very, very grateful and relieved, and the sister was saying, well, we didn't want her to live like this was torturous, this was her suffering, and all the rest of that. But I had a significant amount of moral distress. Why did I have a significant amount of moral distress? Because I had an expectation of what my job was supposed to be and an expectation of what was supposed to happen versus the reality of what happened. And there was a big gap between those two things. And my definition of suffering is the gap between my expectation of reality and my experience of reality. So, is that because you didn't engage with her directly? That's a really good question. So the question was that because I didn't engage with her directly? I think that's a component, but I want you to hold that thought because we're going to unpack this a little bit more. So, my moral distress, your moral distress, everybody has experienced that mismatch between their expectation of what was supposed to happen and what their experience of what actually happened. Everybody in the room has experienced some level of moral distress. How we resolve it is important because What I don't want to do as a practitioner is take that experience to the next time I am asked to see someone in a similar position and run a mile, because that's what I feel like doing. Every time I get a similar case, I want to run a mile. So, how do I do that? The Queen of Reflection is in the room, so I am such a fraud, Kate, and yeah, I feel like you should be talking about this, but anyway. Yeah. So everybody can talk to the simplicities of reflection, that's fine. And then I think you go up the gradations of this to think about what is reflexivity, what is critical reflection when you bring in questioning, examining knowledges, beliefs and actions, and then hopefully get to some form of reflective practice. Now, I've had the benefit of participating in reflective practice and clinical supervision and courses to do that, and I think it's hugely beneficial. But I think for those of you who haven't, doing it with some trusted members of your team is super beneficial. So, what's the difference between that and moral reflection? Well, moral reflection, because I can't say those words together very well, the benefit of that is it also studies the reasons behind making decisions. So I was like, okay, well, if we think about why we're making some of those decisions and then reflect on what it is about those decisions, can I help bridge that gap between the expectation and reality? So how do we make moral decisions? This guy's a psychologist from, I want to say University of Chicago, but yeah, Kohlberg. And I think he did a ton of research and talked about different ways that people develop a moral framework. So often I want to be up at stage 6, but I function down at 1 and 2. I do something so I get something out of it, and I do something so I don't get into trouble. Now, what I'm trying to do is shift my percentages of time that I'm spending in stage 1 and 2 to spend more time in stage 5 and 6, where I do something because of the social contract I have as a practitioner and as a person, and then also because it's the right thing to do. Now, hopefully I'm doing that more and more, but sometimes I'm not so great at that. And I think having a think about why we're making some of these decisions can help guide us in terms of our reflection. So, the moral reflexivity, lots of definitions. I should have put that at the start as well. I use lots of funny definitions. So the moral reflexivity component comes in when we're having an experience and we look at what happens after that, and we cast this critical or judgmental eye over it and saying, is this a just assessment of both the circumstances that we found ourselves in, but also our conduct in those circumstances? So could I have changed the circumstances? Well, no, not really. But could I have changed my conduct? Yeah, potentially. And so how do we look at whether that's reasonable? So what is the point of all this? I was getting to it. The point of all this is that hopefully we can think about ways that we have a decision mismatch that could potentially lead us down a pathway of distress. And then hopefully we can think about some of the decisions that we make every day that are emotionally evocative and complex, and we can look at ways to alleviate some of them. Because let's face it, not many people teach you about how to prepare for emotion and the result of your decisions. And it's something that I'm very, very interested in, not just for my professional development, but also how to teach other students to be doing, because I think this is something, one of the biggest gaps in medical education, but that's for another talk. So, how does this affect rural communities? Well, it's massive, because I walk down the street and see one of the disability support workers, or I go to a separate function and run into the sister or something, right? And so this is very, very impactful, because in smaller communities, you see these people again and again, and believe me, it's reactivating. So I was reactivated multiple times by thinking about some of these cases and how that case played out. So herein lies the challenge. How can we facilitate memorable learning experiences that improve that moral mismatch, thereby reducing our suffering? And how can we reflect as a group outside of that one-dimensional outcome that says everyone's been to debriefs and they say, okay, well, this was the process. How do we fix the process? That's fantastic. It's a one-dimensional, really process-focused debrief. So what these guys came up with is a 4Ds model that looks at an emotion-focused debrief. And the point of the emotion-focused debrief is to say what's different about that case, what's a discomfort, what was disruptive, and what's a departure. And this is the basis of a transformational learning experience. Again, lots of words, but the transformational learning experience is supposed to be a way that reframes and looks at your expectations to be more open, more reflective, and more emotionally able to change. So, ultimately, we're looking at some kind of deep structural shift in the way you think about something that dramatically and permanently alters your way of being in the world. Sounds deep, right, for a Thursday? Is it Friday afternoon? Yeah. So, how do we go back and look at what was the 4Ds framework of that case? What was different about this 53-year-old woman? Why was this a transformational learning experience for me? Or why could it be a transformational learning experience for you guys? What was different about it?
You said yourself the absence of an actual diagnosis.
Sorry,
You didn't have a terminal diagnosis.
Yeah, 100%. So no lack of terminal diagnosis, that's a massive difference in terms of an entry point to palliative care, isn't it? What else was different?
You didn't have the ability to communicate with the client themselves directly.
100%.
So you were using everyone else's perceptions.
Absolutely. Perceptions and what else? Assumptions, right? A ton of assumptions about what was... This woman had no real advanced care planning. She was intellectual capacity of a 9 or a 10-year-old. Therefore, yeah, sure, her sister may have had some ideas about that, but no advanced care planning. So that was different. What was uncomfortable?
Well, probably it leads into both. You were talking about distress, but there seemed to me, listening to that, I was feeling quite traumatised. So I think there was a level of moving up the scale from distress to trauma, and that is a very uncomfortable position for us to be in.
Great learning opportunity though, right? Because apparently mistakes are the best opportunities to learn stuff. And so I figure that if we're thinking about what is it about a mistake, why do people say that? So they say, oh, okay, well, if you make a mistake, you're going to learn from that. But are you really going to learn from it? Because unless you actually kind of do some of this with some people that, like I have a really good team of people that I work with, they're very interested in some of this stuff. And so we do have the opportunity, I get to have the opportunity, fortunately, to think about some of these things and talk about them. But unless I'm doing this, I'm not really learning from it, right? And that's what I think that's one of my other bugbears. Why do people say we learn from stuff just because we could keep repeating the same mistake again, right? Isn't that Einstein's quote about insanity? You keep repeating the same thing over and over again, expecting a different outcome. So absolutely, it's going to be uncomfortable because it's a situation in which you don't normally find yourself in. I don't normally find myself in a situation where I'm treating a 53-year-old woman with intellectual impairment and thinking about her terminal kind of lack of terminal condition and then potentially her dying. Why was it disruptive to my worldview? What was the disruption? I'm out of control, someone said. I was absolutely out of control. And it completely disrupted my notions of what am I supposed to do in a situation where I'm very good at patterns. I'm a pattern recognizer. That's what I've been taught how to do. But this didn't fit a pattern. So it disrupted my ability to interpret a pattern. Why was it a departure? And what was it departing from?
The uncomfortableness, I mean, the fact that, it's going to sound gross, there was a sigh of relief amongst the nursing staff when she shut up.
Yeah, 100%.
And that you're sedating somebody to give yourself a sense of relief. You didn't know whether you were giving her any relief, but you were giving everybody else on the ward relief. So that makes you feel guilty, and I feel guilty for you.
Okay, yeah, thanks. So I'm going to offer that there was a departure from what I would normally do and what I normally know in terms of how to manage things. And so there's this massive amount of uncertainty. Now, PAL care is uncertainty, right? We don't deal in black and white. I'm very happy with that. Like grayscales are exactly where I'm more comfortable. But this was a significant departure from a case that I would normally be involved with. It was a significant departure from how I would morally kind of come to a decision-making. Like, as my decision-making ability, if we look at my moral reflection of this, how was I doing the right thing? It was a significant departure from what I would normally be able to say with some level of certainty, not always, but some level of certainty, that I was doing the right thing for the right patient at the right time, right? Governance is a massive part of everything we do, and that's what I'm trying to do, and that's what I'm trying to teach my trainees to do, but absolutely, I'm not sure I did that here, right? And that's why it was a departure from that. So, in summary, because I'm probably getting to that point, moral reflection is a really interesting way to look at the reasons behind our decision-making. Moral distress is definitely possible and probably happens to every person in this room if you've made a clinical decision, even if you made a decision about like which restaurant to go to, right? I mean, no, it really is. Any decision you can get to a point where you have a significant gap between your expectation of what is going to happen and your reality of that experience. And that is your suffering. And I guess what I'm saying is that unless you have an avenue to think about ways to resolve some of that, you will take that to your next interaction with that circumstance. And I'm urging you to try and think about some of the things that perhaps you have an emotional reaction to, and perhaps some of the things that you think, oh, gee, why am I avoiding that? What's that about? Is that because I have some moral residue, which is another great term, thinking about this like residue on a pan that I had previously from a moral injury or a moral distress that I bring to the next case that I see. And I think that's my truth and the experience that I've had. And using some of these frameworks with palliative care, I think palliative care is a really useful team environment to have a think about that, because you do get different perspectives. You do get the opportunity to have a range of clinicians involved in talking about this. We don't have a psychologist in the whole hospital, unfortunately, but for those of you who do have a psychologist, I'd suggest that, you know, that's an important person to bring into some of this as well. And I think moral reflection can precipitate some really useful changes in you, in others, and hopefully in systems if people start adopting it in a greater capacity. So, if you wanted to have a look at the articles, I would highly recommend the second one. That's what I stole the whole talk from, the 4Ds model. And none of this stuff is original, none of it's my idea. It's all basically in there. So do have a look at that. I think it's a really good article, and definitely something to maybe do at a journal club or have a think about doing as a team if you get the opportunity.
Thanks, Aaron. I saw you tip your hat to Kate Munro in the audience. And for those who don't know, Kate Munro is a giant of end-of-life palliative care, compassionate communities. She really is. And I just wondered, Kate, if you have any comment on what Aaron presented. Yeah, I could see you looking very thoughtful, and I was dying to hear what's in your mind. So please, what did Aaron's talk prompt for you?
Thank you. And for all of you, you need to know that I'm a fully paid up member of Aaron Veltre's fan club, okay? Just need you to know that, because he challenges me all the time. I loved this, that you changed the thing. That was great. Fabulous. And because palliative care changes on a minute-by-minute basis. And you've presented something that I think is not unusual. The actual case is unusual, I guess. But in that sense of, what do we do with my distress? And I loved when you said you like phoned a friend, or 3 or 4, because you needed to bounce off how you were feeling and how it was going against everything that you believe in. And, you know, I think one of the things that we've learned out of COVID is that we have nowhere to tell our stories. We have no way of gathering and listening to each other's stories. And I think in palliative care, we're not always very good at that either, of listening to our stories. And I think one of the things that we started to do was run this little program, which is based on reflective practice and strength-based approach, is asking people to tell me how they feel. So we did it in a mental health unit, where they had a client that they had no choice, they had to take. It was very conflicting, very difficult, very challenging. And we went in and we said, okay, we're going to run a program called Being Heard, Being Acknowledged. So each person was given 5 minutes to tell me how they felt, feeling, emotion words about that person. And you had a choice. You could say, no, I don't want to talk. Quite a few people said that, and then at the end they came in and talked. The thing that came out of that was staff who work so closely with each other every day, know everything about their families, know how long it takes to drive to work, know what they love to eat for lunch, had no idea how their staff was feeling about working with that client. Now, the transformational learning out of that was they became much more involved in having a say in what happened for that patient and for themselves. And, I think what you were talking about, where do you take this stuff? You don't have a psychologist, I get it. You have social workers and you have lots of other lovely people. But I think you challenge us to think about, oh my God, that is so far outside the box. I actually don't know where to go with that. And the language that we use of going, okay, how do I clinically reflect on that? And so thank you for bringing it, because I have no idea. I don't know.
Don't say that. You're the expert at this. You can't say you don't have any idea. No, you
have to reflect, though. But you have to provide a safe space.
You do.
And, you have to make it safe for people to say, you know what? I was so glad, as that lovely doula said, I was so glad that woman stopped screaming because I was like hearing her in the middle of my sleep. So, yeah, there's an element of, for us, making it quiet. But where do we take how we feel about stuff? Because in health, we don't want to know. It's not okay to tell me how you feel about something. Palliative care are pretty good at it at one level. But I think we have lots of clients like this that challenge us in what we believe is our core principal values around who I am as a human being, but also who I am as a palliative care clinician. And I think all we have to do is deeply listen to each other and care and actually ask how I'm feeling, but genuinely ask how I'm feeling in a safe space. And I know where you work, and I know the people you work with, so you have good people who will listen. There are no answers often. I mean, that's the quandary, isn't it, of working in palliative care often. There are no answers. And our clients, our patients are getting much more complex. They're much more complex. They're bringing much more complexity to our moral distress of how do we manage stuff. So, but I thank you for that, because I'm sitting here going, oh, I've got to go away and think about this now. This is, my brain's going 9,000 miles an hour. But I just want to acknowledge the fact that you are a trailblazer in education for your medical students, in asking them to critically and clinically reflect, because that's not a norm. So thank you.
Oh, thank you, Kate. I think we spent so long talking about process debriefs, and it wasn't until I did clinical supervision with you and started understanding more about emotion-focused debriefing and the importance of that, because that's the work, right? And that's what I want to get to, and I want to evolve as a practitioner. That's the work. I don't care about the drugs. The drugs do their thing and they do all the rest. That's fine. But I want to get better at that. And so that's why I'm so grateful for the stuff that you do and the stuff that you've done for me, because it's a huge part of why I do the job.
I suspect more than one of us in this room feels like we have a little bit of moral residue that we could, maybe also have the courage to pull out and take another look at. So thanks for sharing that deeply personal story. And I think we've learned a lot from the way you worked with it personally. So thank you.